Natália, som e imagem perfeita.
Hi, Aline.
Oh, how are you?
Fine, and you? How do you do?
Good, good. We figured it out.
Yes, finally.
I'm sorry, I just done scoping, so I'm still in my scrubs.
You
And
are
I'm,
incredible.
yes. All right. We figured it out.
So, yes, finally. So it's 7 p.m. now in Brazil,
Okay.
and I'm just gonna give some instructions in Portuguese very quickly, and then we can start, okay?
Okay.
Pessoal, muito obrigada por vocês que estão aqui assistindo. A ideia é fazer um bate-papo bem informal sobre alguns temas que a gente selecionou do AIBD, com foco na vacinação para a Covid, que eu acredito que seja aí o tema mais quente. E sintam-se à vontade para enviar perguntas em inglês, em português. A gente tentou endereçar todas as dúvidas que normalmente surgem, mas se for algo que não esteja no nosso script, eu sem dúvida vou tentar fazer essas perguntas, ok? So I'm gonna start introducing Aline. Aline, she's medical director of the IBD Center from Johns Hopkins in Washington, D.C. She is a friend. She's a really inspirational woman in IBD, very remarkable person in the IBD field. And I'm really proud to be here with her today.
Well, I'm very excited to be with you today, Natalia. You're absolutely an amazing figure in inflammatory bowel disease and an amazing inspiration for all women in medicine. So thank you for having me. I'm excited we're doing this together tonight.
Thank you very much. So let's gonna start talking about AIBD. What does AIBD represent to you?
You know, I started going to advances in IBD when I was a fellow and interested in inflammatory bowel disease. And I've seen it grown through the years from when we used to be one small room and now it's a big conference. But what is really nice about advances in IBD, even though it's getting a bigger conference, it still feels very intimate. This is really a nice conference where you can really connect with other physicians, clinicians, psychologists, anyone taking care of patients with inflammatory bowel disease. It's very clinically oriented, a lot of case discussion, and a lot of different pathway for fellows, for IBD specialists, for nurses, and it's really, I think it's a great place to network and really create collaboration for research and for publication. And a really great place to learn. So I really enjoy this conference. It's one of those conferences that I never miss. And I'm excited I got to meet you there last year.
Yes.
It was really nice. And that's one of the things that I like. It's really learning. And at the same time, there's this connection that get established with different people from different corner of the world, like not just the United States, but Brazil had a big representation last year. And really have people interested in inflammatory bowel disease from all around the country and the world.
Yes. And you know, for me, it's the same. For me, it's the most practical conference of the year. It's the must-see conference of the year because it's really practical. You can really have access to fresh data through case-based discussions in a multidisciplinary approach. And it's really informative, educational, and quite popular in Brazil, as you have mentioned. Last year, Brazilians represented the second largest delegation, only behind the US. So the attendance is really, there's a lot of Brazilians who really attend AIBD. Unfortunately, I don't have this data for this year, but I'm sure it is more representative because one thing that's better being virtual is that because you can reach many people.
Right, absolutely, absolutely. So we're looking forward to more live AIBD, so to get together again.
Yes, we really miss face-to-face meetings now. Yeah. So let's gonna start with the highlights. We really decided to start with the hottest topic ever, mainly for us today in Brazil. It's a really important day regarding COVID-19 vaccination. I will tell you why. That's COVID-19 vaccination in IBD patients. Okay. First, I would like you to comment on the RNA vaccines that are the main vaccines available now in the US.
Right. So we're very excited. That was really a nice way to end the year, to have the two mRNA vaccine, the Pfizer and the Moderna one, becoming available, and having healthcare workers to start getting the vaccine. They're both messenger RNA. What messenger RNA does, it goes into the cell, not in the nucleus. A lot of people worry it's going to go into the nucleus and affect the DNA. It doesn't go there. It stays in the cytoplasm of the cell, and it's a messenger. It's telling the cell to make the spike protein of COVID. So the cell make this protein and present it to the immunological cells, and then that way we can create a immunological response with antibody and with memory T cells to defend us in case we get exposed to COVID. And we are very excited because the efficacy of both vaccines are more than 95%, which is fantastic. The messenger RNA itself gets destroyed after 10 days. So again, a lot of people have anxiety that this is going to stay there, but it's not. It's just giving a message to the cell to make the spike protein for the immune system to react to it, mount a response, have a memory to it. And so if we get exposed to COVID, then we avoid the illness and severe illness with COVID.
Yes, excellent. So it really mimics the COVID-19 infection, because it really produces the most important protein of the virus.
Exactly.
For us in Brazil, unfortunately, even though we are a hardest hit country, we don't have yet any vaccine approved by our regulatory agents. But we have good news. Today we had the final results, the phase 3 results of Coronavac. That's the most likely to be approved vaccine nowadays in Brazil. It is a vaccine produced in partnership with Butantan Institute. That's a really renowned institute here in Brazil. And its mechanism of action is quite similar to the common flu shot. That's the coronavirus itself inactivated.
Okay.
So it produces a response that ranges around 78% for the less severe cases and 100% against severe cases. And non-patients that received the vaccine needed hospitalization. So we are really, really proud, really happy with this information we got today. And it's very likely that we're gonna start the vaccination program next January 25.
Congratulations on being part of the vaccine development and having the vaccine. I know this is something that is much needed for a country like Brazil and all around the world, to be able to go back to life, to be able to keep our patients and our parents and our family and ourselves safe, and really to go back to normal life. So congratulations on step forward toward the vaccine.
Yes. The second vaccine that's really likely to be approved here is the Oxford vaccine that we also hosted the phase 2 and 3 trials here in Brazil. The Oxford vaccine is being produced in India, and its mechanism of action is quite a bit different because it uses an adenovirus as a vector, an adenovirus inactivated from chimpanzees. So it's a simian adenovirus. And this adenovirus acts as a vector carrying the spike protein of the virus, and then it stimulates our immune system to produce the response. So I think those are the two vaccines that will be soon available here in Brazil. So we need to know how to figure out which populations can receive, cannot. I think those are the most important questions that arise at this moment.
Yeah, so the way we allocating vaccine here is by tiers, and in terms of risk factor, with healthcare worker first, and resident of long-term facility nursing home. And then the phase 1B is going to be for our patient older than age 75 and those with comorbidities like heart disease, lung disease, kidney disease, cancer, obesity, diabetes, smoking. And then it would be for our patient above age 65 and our younger patients. So this is how it's being done here, really based on risk factor of having severe COVID or having a high exposure to COVID. I know we were going to talk about our inflammatory bowel disease patients. Our IBD patients at this point don't qualify as being high risk, even if they are on biologic or immunomodulator. And this is in large due to the fact that we have good data showing that our patients with inflammatory bowel disease, for the most part, are not at high risk of serious COVID. So which is the good news for our IBD patients. What drives severe COVID in our patients with IBD is mainly having active disease or steroids, or having other comorbidities, older patients, patient with heart disease, lung disease. So I know we'll talk more about also specific medication, but at this point, the way our CDC has allocated high risk in terms of comorbidities, our IBD patient don't qualify. It's only patient on immunosuppressive drug for organ transplant that are deemed to be immunosuppressed enough to be at higher risk, but not our IBD patients.
As we don't have yet a detailed vaccination plan, we do not know yet how will be this allocation, but it's very likely that patients with IBD itself, just because of IBD diagnosis, will not be prioritized to this first phase allocation groups, because all the evidence we already have that patients with IBD do not have a higher risk of infections or COVID-19 complications. So if a patient has a comorbidity or use or another risk factor, then it's possible to be prioritized.
Correct, correct.
So the next topic that we would like to address today is regarding the safety and efficacy of the vaccine in our IBD patients. So I think it seems we are more concerned regarding efficacy than safety, because we have for a long time our patients being vaccinated against pneumonia and against flu, with any evidence that those vaccinations could trigger any kind of flare or worse disease activity. But what about efficacy of the vaccine and the influence of the IBD treatment?
Yeah, that's a great question, and I agree with you, Natalia. Based on our vaccines, all vaccine, one of the concern that our patients with IBD have is that the COVID vaccine were not tested in an IBD. But, all the other vaccine that we give our IBD patient also were not tested in our patients with IBD. IBD patients are usually excluded from trial of vaccine. But based on our prior experience with vaccines that are not live virus vaccine are safe for our patients with IBD. And all the vaccine developed against COVID, none of them is a live virus vaccine, like you detailed. It's different mechanism and different ways of doing vaccine, but none of them are live vaccine. So they should be safe, and they are safe and we're recommending that our patients with IBD get the COVID vaccine. In terms of efficacy, we also don't have much data on how effective the vaccine for COVID is for our patients with IBD, mainly if they are on immunomodulator or biologic. So we have to rely on our experience with other vaccines. And what we know is that for vaccine, like for the flu or the strep pneumonia vaccine, patients who are on some immunosuppressive drug have a lower response to the vaccine, less efficacy, mainly patients who are on combination of anti-TNF with an immunomodulator, whether it's azathioprine or methotrexate. So being on combination anti-TNF and immunomodulator decrease the efficacy of the vaccine in general. Being on drugs like vedolizumab or secukinumab does not seem to decrease the efficacy of the vaccine. Now, what we also are looking at from prior experience are vaccines that are not as effective as the COVID vaccine. So usually the flu shot is like 50 to 60% effective. So if you are on immunosuppressive medication and that efficacy drops to 30 to 40%, it's good, but it's not great. But when we have vaccines that are effective more than 80%, 90%, 95%, even if the efficacy is a little bit lower, it's still better than being exposed to COVID. So they're still giving good protection compared to no protection and getting a severe illness. And we also don't know if these vaccines, by being so effective in the general population, it might be that that's because they trigger a good immune response, maybe in everyone. So we have to see and we have to follow, but we do believe that these vaccines are safe to take for our patient. They're going to be effective. And even if the efficacy is decreased a little bit, it's better to get the vaccine and be protected from a severe illness than not to take the vaccine.
So as this is a really, really important message to our patients and IBD physicians, I would like to ask you permission to translate this message.
Yes, please. Portuguese, it must be prettier.
Então, pessoal, essa é uma mensagem muito, muito importante. Até o momento não existe nenhuma evidência de que a vacina, qualquer uma delas que esteja em desenvolvimento, tanto as vacinas de RNA, quanto a vacina de Oxford, que é uma vacina que utiliza um vetor, quanto a vacina Coronavac, que provavelmente é a que os primeiros brasileiros irão receber, não existe evidência que essas vacinas não sejam seguras nos nossos pacientes com doença inflamatória intestinal. A maior preocupação é com relação à eficácia, que pode ser um pouco inferior, porque nós já vimos que a vacinação para a influenza, por exemplo, é um pouco menos eficaz na população com DI que está fazendo uso de imunossupressores, principalmente a terapia combinada com anti-TNFs e imunossupressores. No entanto, quando essas vacinas são muito eficazes, muito acima da eficácia da vacina para gripe, por exemplo, 95%, 80% de eficácia, é muito provável que essa eficácia um pouco reduzida na população de imunossuprimidos não vá interferir, é muito melhor do que a ausência de proteção, visto o risco da infecção pelo COVID. Então, nós recomendamos fortemente que todos os pacientes com doença inflamatória, independente do tratamento que esteja recebendo, sejam vacinados assim que a vacina estiver disponível. Lembrando que não existe nenhuma vacina em desenvolvimento que seja a partir do vírus vivo. Então, pode ser que essa recomendação mude ao longo dos anos. It's possible that we can update this recommendation because it's possible that a live vaccine simply appear, but up to now, the recommendation is that all IBD patients should get the vaccine. Então, até o momento, gente, todo paciente com DI deve receber a vacinação para COVID assim que a vacina estiver disponível. Essa é uma mensagem muito importante que a gente gostaria de passar para vocês hoje, ok? So I think we can move on to the next topic that's regarding COVID-19 in IBD patients. So is there a real risk of COVID-19 in IBD patients irrespective of their IBD treatment?
Well, this is a great question. I think we were all very concerned about our patients with IBD on immunomodulator and biologic when the pandemic started, and patients were concerned and physicians were concerned. But as you know, we have great registries, including the SECURE-IBD registry, that collected information about patients with IBD who developed COVID. And from what we have from this registry, is that biologic do not seem to increase the risk of serious COVID. So patients on anti-TNF, like infliximab, certolizumab, adalimumab, patient on vedolizumab, on ustekinumab, are not at increased risk of severe COVID. But what the SECURE-IBD registry is highlighting is that being on steroid increases the risk of serious COVID. So if you develop COVID while on steroid, we know that steroid decreases the immune system and increases the risk of infection. There's a high risk of developing severe COVID. And also being on a thiopurine, so azathioprine, mercaptopurine, we know that these medications increase the risk of viral infection. So it was expected kind of to see that. So we do see that patients on thiopurine have a higher risk of developing serious COVID. So the recommendation from the SECURE-IBD paper is that if we have patients on azathioprine and a biologic, and they're stable and they are high risk of exposure, maybe remove the azathioprine. But the most important message is that if you're on a medication that's keeping your disease stable in remission without steroid, that's what we need to stay on, because it's really having active disease that's going to take you to the hospital and being admitted and increase risk of exposure, and being on steroid to control the inflammation that is going to really increase our risk. So in my practice, if a patient is stable, even on thiopurine, I keep them on it. Everybody should take the precaution for COVID, the mask, the physical distancing, hand washing. If they're on combination, I remove the azathioprine. If they're on biologic, we continue everything. And if I'm starting a new treatment for my patient, I still choose what is the best that's going to control their disease. So if a biologic is the right choice, that's what they're going to have. We have good data now showing that it does not increase the risk of serious COVID.
I will translate that important message as well, but we have an interesting question from a very friend of mine, that is Dr. Mateus, who works with me in Clinics Hospital. And he is asking an interesting question regarding if do you think it does work to really collect the antibody level following the vaccination to see if it does really work? In my opinion, as the different vaccines stimulate different immune response from memory T cells and antibodies, it's possible that even though we don't have high levels of antibody, that the vaccination is still giving some response to the patient. But what's your opinion on this?
A great question, and I totally agree with you. I think first of all, I think there are a lot of people interested in measuring the level of antibody to the to COVID, against COVID, in patients with IBD getting the vaccine. And I think there's a lot of talk in different institutions to do this kind of study. But it's very important, like you said, to remember that antibodies are not everything. Even when antibodies decrease, there's still the memory T cells that will react when the body exposed to the virus. I mean, think about all the other vaccine. All of us have been vaccinated, for example, for hepatitis B, and then sometimes you check for antibody and you don't find them. But we know that if we get exposed, we're going to be able to react to it. So I think the important thing is really to see if, at least as an initial response, if our patients with IBD have the same initial response, same antibody level, or same percentage of patients who develop an antibody. And if that, I think, will be indirectly reassuring that it's a similar response, that the memory T cells will take over later, even if the antibodies doesn't persist. I think that if somebody mentioned that if we had persistent antibody for every vaccine, it would be too much for our body. That most of the immunity really comes from the T cell on the long term.
Então, pessoal, com relação à pergunta super interessante do Matheus, é possível sim dosar esses anticorpos após a vacinação. No entanto, isso não vai significar que o paciente tem ou não tem a resposta imune à vacina, porque a vacina também induz outro tipo de resposta imune pelas células T de memória, que não é só medida através da dosagem de anticorpos. E a segunda mensagem, now I'm gonna move to the second message regarding IBD treatment, que é muito importante que os nossos pacientes mantenham o seu tratamento, que deixe o tratamento que esteja mantendo o paciente sob controle da sua doença, porque nós já temos bastante evidência, bastante dado, nos reafirmando que os desfechos mais desfavoráveis da COVID não se relacionam ao uso de anti-TNF. Nós temos, sim, um pior desfecho com os imunossupressores. Então, é possível, se o paciente estiver bastante estável, de remover o imunossupressor quando está em comboterapia, mas a regra geral é que os pacientes mantenham o seu tratamento, porque o pior risco é o uso do corticoide e a doença em atividade. Se o paciente suspender o seu tratamento e voltar a ter atividade, ele vai ter um risco maior de necessitar, uma necessidade maior de ser internado e de usar corticoide e, assim, se tornar de maior risco para desfechos desfavoráveis da doença. Okay, so let's move on to the next question, that is regarding the updated data from SECURE-IBD database. That's really reassuring. I've checked on the last data on December 22, and we have the incredible amount of reported cases of more than 4,000 cases, with death fatality rate of 2%, and the combined outcome of ICU, ventilator use, and death of 5%. So it's really in line with what we already see for other populations. Do you have any comments on that?
Yeah, this is, I think, very reassuring for our patients with IBD, that their risk of getting COVID or having severe COVID that require ICU stay or that can unfortunately result in death is similar to the general population. So having IBD alone does not put patients at higher risk for serious COVID. And the risk factors of developing serious COVID and needing ICU are similar to the general population in terms of age and comorbidities. So that's, I think, very reassuring for our patients with IBD. It doesn't mean that they should stop, be careful and take all the COVID precaution, because one of the things also that can happen is that when you get infected with COVID, we have to stop the medication for your inflammatory bowel disease, and then we're dealing with a flare, and then it becomes very complicated to manage an infection and a flare at the same time. So we want our patient to be healthy and not get infected, but in case they get infected, they're not at higher risk than the general population to develop serious complication.
Yes, and now we have a quite interesting question from a patient. That is, what's the best moment for the vaccination? Is it between 2 doses of biologics? Is it necessary to hold the medications if you are receiving the vaccine? Would you make any recommendation on that?
This is a great question, and that's the question our patients have the same concerns all around. There's no need to hold or an infusion or medication or to time it compared to your injection or infusion. So you can have the vaccine at any time. The one thing I would recommend, a medication or like an injection or infusion recently, then don't take the vaccine the same day, just in case you have a reaction to one of the drugs, so that we know which one is causing the reaction, right? So if you're getting your infliximab infusion or your adalimumab injection, just don't do the vaccine the same day if you just started recently on the treatment. So if you have a reaction to the drug, we know it's the drug or the vaccine. The other recommendation is not to take another vaccine the same day. So if you're getting your flu shot, don't get the COVID vaccine the same day, again, for the same reason. So if you react to one or the other, we know which one you're reacting to. But otherwise, there's no need to time it in between injection, between infusion, delay. You don't need to do that. Just don't do it the same day. So that in case you react to one, we know what's causing the problem.
Então, gente, essa é uma pergunta que ela ficou impressionada, porque os pacientes no mundo inteiro fazem a mesma pergunta, os pacientes dela perguntam a mesma coisa. Não existe necessidade de adiar a infusão ou fazer depois de um tempo de que você tomou a sua medicação. No entanto, existe a recomendação de que você não faça a vacinação no mesmo dia em que você vai utilizar o biológico e nem outra vacina no mesmo dia em que você for utilizar a vacina contra a COVID, pelo motivo simples de que se você desenvolver alguma reação alérgica, alguma reação adversa, vai ser difícil de identificar o que causou essa reação, se é a medicação ou se foi a vacina contra a Covid. Então, essa é a única medicação. Não percam a chance. Assim que estiver disponível no seu dia, vá lá e tome a sua vacina. So, just when it's ready, available, just get it. Just go
Just
there
get
and
it.
get it.
Don't lose your chance to get that shot. This is your shot to get the vaccine. Don't lose it.
Yes, exactly. So I think we already went through all the COVID-19 stuff from AIBD, and another point that we selected to highlight here is regarding the final results of the Piano registry. That's really important for patients and patient advocates. The Piano registry is it means pregnancy and neonatal outcomes after fetal exposure to biologics and thiopurines among women with inflammatory bowel disease. And the take-home messages of the final results were that patients receiving pregnant patients receiving biologics and/or thiopurine didn't have an increased risk of congenital malformations, spontaneous abortions, preterm birth, low birth weight, or infections in 1 year.
Yes, this is a landmark study and a very exciting result. A lot of our patients develop or manifest inflammatory bowel disease when they're young and they are in childbearing age, and they are worried about getting pregnant on the medication. And so this is very worrying for patients and for physicians. And the key message here is that these medications are safe during pregnancy. We should not stop them during pregnancy because they do not increase the risk of malformation or negative pregnancy outcome. On the other hand, if we stop medication, patient can flare. And Piano study, along with other studies in pregnant women, show that if a pregnant woman flare, the IBD flare during pregnancy, that can increase the risk of problem. That can increase the risk of spontaneous abortion, prematurity, low birth weight, and infants who are premature are at high risk of infections and other complications. So the key message here is, like you said, these drugs are safe during pregnancy. We should keep our patients who are on thiopurine or biologic on these drugs throughout the pregnancy. They don't increase the risk of problem. And on the other hand, if we stop the medication and the patient flare, this is what's going to lead to negative pregnancy outcome.
Então, uma mensagem muito importante do estudo Piano, que é um estudo que avaliou o risco de biológicos e imunossupressores na gestação. Então, imunossupressores, leia-se azatioprina, viu, gente? O metotrexato está contraindicado na gestação. Então, azatioprina, mercaptopurina e biológicos anti-TNF, todos anti-TNFs, ustekinumab e vedolizumab, não causam desfechos desfavoráveis durante a gestação. São medicações seguras, não causam problemas para o recém-nascido, que foram seguidos até 1 ano de vida. Então, são medicações que devem ser mantidas durante todo o curso da gestação. Essa é uma mensagem muito importante que esse estudo, Piano, estudo conduzido pela doutora Uma Mahadevan, que incluiu mais de 1.700 pacientes gestantes, nos traz bastante segurança para que nós possamos manter as medicações para os nossos pacientes durante a gestação, certo?
Yes, and it's important to realize also this study was started in 2007 until now. So we really have many years now of experience, almost 1,500 women. And also the children are being followed. And so far we have data in up to 1,000 infants up to a year. And they all reach all their landmark. There's no increased risk of infection. They're all developing well. So it's very important to know it's safe during the pregnancy. And then for the infant, they are developing absolutely normally for the infant who were exposed to these drugs when they were in the mother womb.
Excellent. We are almost coming to an end, but I would like to highlight the editor session. This year we had the editor sessions. That's when The editors of the most important gastroenterologist journals from IBD or in general were invited to bring us the highlight papers from 2020. And Professor Colombel presented the study that was first authored by Paulo Cozzi, which we are really proud of him. And that's regarding the progression of IBD through Latin America and the Caribbean. A really important study for us that reported that the incidence and prevalence of IBD have steadily increasing in Latin America and in the Caribbean, and the incidence of Crohn's disease in Brazil increased from 0.08 per 100,000 person years in 1988 to 5.5 100,000 persons year in 2015. And the ratio of UC and Crohn's disease exceeded 1 in all regions throughout Latin America and the Caribbean, with the exception of Brazil. So I would like us to discuss the reasons for these findings once you have recently led a conversation on Monday Night IBD regarding the epidemiology of IBD in the world.
Yes, there was a fantastic paper by Gil Keppel looking at that. And really what we have now is a increase in the incidence of IBD all around the world, including in countries like Brazil, where the incidence was very low, 20 years ago. So the question is, what's going on? Our genetics don't change that fast, right? Genetics don't evolve so quickly. So it must be something in the environment. So there's definitely a concern that our environment is changing the way we're living, we're eating, what we're doing. It's changing in a way that is putting us at higher risk of inflammatory bowel disease, because we see an increase in the incidence in countries that are becoming industrialized, and where and within the US or in already industrialized country, we see a difference with increase in IBD in the cities compared to the farm country. So there's definitely something in our lifestyle that has changed. So what has changed? Food has changed, the way it's done, the way it's processed, added sugar, preservative. The way we're living, we are less active. We have more desk jobs than walking and being physically active all the time. Smoking is a big risk factor for Crohn's disease, and probably more other things that are more subtle, between stress and lifestyle and just different environmental factor. And I think that is the difficulty in studies that try to find the one thing that changed things, or the one thing in the diet. So is it red meat? Is it this, is that? I don't think we're going to be able to pinpoint one thing. It's really like a overall change in our lifestyle. The other thing that could be going on also is that now there's more awareness and we have more way to diagnose. And so maybe some patients used to have IBD and we didn't know, and people didn't like to talk about diarrhea or GI problems, and then they kept it secret, or they didn't address it. So I think there's definitely an increase in the awareness or reaching to a physician, but there's definitely also an increase in pure incidence, probably related to our environment, from pollution to diet to lifestyle to habits. And it's very important to be aware of that, because it's hard to go back to how we used to live. But I think it's important to understand that when we talk about healthy living, it's not just stylish thing. It's important for our health, but also it's very important for our health system, our physicians, our clinicians, our patients, our general population to be aware of that problem, so that they can recognize it early, treat it properly before complication happen, but also for health system and countries to be ready for this increased risk in a disease that is chronic, where treatment is costly, in a disease that often involve hospitalization and multidisciplinary approach with IBD specialists and surgeon and nutritionists, etc. So I think this data is absolutely important. it helped us think about what are the factors driving this, but also it helped us think we need to be prepared and ready, and what can we do to be ready and not have the system being overwhelmed and patient not being taken care of properly because we don't have enough physician or facility or medication to take care of everyone.
Yes. So as a newly industrialized country, we are now facing the phase where we have high incidence and yet not so high prevalence, much lower than we have seen the European countries. And now we have two persons that are experts in IBD epidemiology here watching us. That's Dr. Rodrigo Gasparini and Dr. Renata Frois, and she's saying us that's important to understand this epidemiological process, to really get prepared for this in terms of public politics, in terms of health system, to do not get overwhelmed with and it's important because we don't have yet many IBD physicians, we don't have specialized care. There is a huge lack of IBD specialized people, multidisciplinarity here in Brazil. And I think initiatives like this, educational initiatives, can really make people think about this and want to treat more, to take care of those patients.
Absolutely. It's really important to be prepared, and data, that's what data is so important. It's not, oh, I'm seeing more IBD patient, you're feeling like you're seeing more. It's true data, and seeing that increase and tremendous increase is really an issue. And again, we're seeing this also in the United States, where we're seeing a higher incidence now, an increase in the incidence of IBD in minorities and in immigrants coming from countries where there's low incidence of inflammatory bowel disease. In the first generation, the risk of IBD becomes similar to that of the US population. So I think this really highlights how much the environment has an impact, where your risk changed in your lifetime. So I think this is really an opportunity to study what is it in the environment that's caused this, but really also be prepared for public health policy and its health system, and be ready to take care of these patients.
Yes, so I'm gonna quick wrap up this information for our attendance. Então, pessoal, o que a gente está falando é que a incidência tem aumentado bastante da doença inflamatória aqui no Brasil. A gente está vivendo hoje o que os países desenvolvidos viveram há 20, 30 anos atrás, muito por conta da mudança do nosso estilo de vida, mais alimentos processados na dieta, e muitas outras coisas que a gente não sabe ao certo, mas que não é isso que é o mais importante. O mais importante é se preparar para essa nova onda que está vindo, essa prevalência aumentada, onde nós vamos precisar de vocês, IBD especialistas, pessoas que trabalham no cuidado multidisciplinar do paciente, nutricionistas, psicólogos, enfermeiros. Então, é muito importante esse tipo de iniciativa, é muito importante o trabalho que o GEDIIB está fazendo para trazer vocês para perto, porque nós precisamos estar preparados para essa alta prevalência de doença inflamatória em nosso meio. So, Aline, I think we are getting close to an end. I'm very, very happy. It was the first live of my life, but I really enjoyed it.
Me too.
So,
Me too.
I'm gonna let you give the final words.
Well, I just want to say that Brazil has a special place in my heart. I remember growing, I'm Lebanese, and growing up, I would hear about my relative and grandfather who immigrated to Brazil when things were not well in Lebanon. So I know there's this connection, and I had the opportunity to visit Sao Paulo a few times a few years ago and meet the amazing people of Brazil. And I think we are very connected. There's a lot of energy and enthusiasm, and we care for others, and even under difficult condition. I think that's what was impressive to me, that even under economic burden and difficult condition, people just enjoy life and they want to make other people's life better. I definitely looking forward to visiting one day. But I think in terms of IBD, we're really living in exciting times, in a sense that we have therapies that are effective. We're understanding the disease better. We're understanding better how to provide therapy. But at the same time, there's an alarm here, like you said, that the incidence of IBD is increasing and we really need to be ready. So this kind of conversation, I hope, raise awareness about the current issues. And I hope that people out there who are listening today will be encouraged to get vaccinated when it's available, encouraged to use effective therapies to control the disease, and really have a open and honest discussion with their physician when they worry about a drug, when they worry about their IBD. Talk to your doctors, because we are here to give you answers and to help you through this journey. This is a chronic illness, unfortunately, but you know, there are amazing people like you and like many of your colleagues who are there to take care of patients and do it properly.
So, thank you for your words. Thank you very much. And muito obrigada, pessoal, todo mundo que está aqui hoje. Muito obrigada pela presença e espero que a gente possa ter oportunidade para fazer outras lives como essa. So, have a good night. Thank you very much again.
Thank you. Have a good night.
Bye.